the entire case system, you're trying to help them out because of the time limitations on these cases. There is a first appearance in court, and at that time, we look at what's going on in a way that can we offer you any type of treatment? Is there anything we can do as far as supplying an evaluation for you? We have a meeting that's called a pre-hearing conference. And at that pre-hearing conference, we don't talk about the allegations involved in the court system. What we talk about is what do you need? And we get some people that are outright able to open up and say, what I really need is help with my medical concerns. What I really need is to get into treatment. I don't have money. I don't have any resources. I don't know where to go. So, as a team, that's what we try to provide early on. Also, in at least in my area, and I work in a lot of the smaller communities, the judge and the county attorneys allow for what's called immunity. So if someone with substance use decides that they want to get help, even before we go to trial, they have immunity if they receive an evaluation. They receive immunity if they release medical records to the team so that they can't be used against them in a criminal case. Also at that time, we're trying to set up visitation because sometimes these kids are removed from, let's say, the mom right at the time of birth. And we're trying to keep some kind of bonding going because that's, as you know, is very important in the very beginning. So just a little bit, here's our flow sheet. As soon as we get these cases and kids are removed, it can be a lot worse than just somebody going to jail for a short period of time. You lose your custody, at least temporarily, of your kids. And a petition's filed, judge signs an ex parte order. Then we have that pre-hearing conference that I just talked about. And we do a protective custody hearing, and that's just a probable cause to say right now we've got enough information to show that we need to have the kids removed from your home. Some of these parents are in jail. Most of the jail systems do not allow for visits because we don't have a very good way of doing it. You can't really do much of a video visit with kids that are under the age of 2. They're not going to stay on there. And like I said, bonding is definitely a very difficult thing. Adjudication hearing, which is our trial to show what's going on in neglect abuse cases, take place sometimes 3 months after these cases are opening up. And the problem with that is that maybe there are parents that don't want to do anything until, their attorney might tell them, hey, let's wait until we go to court to do any of these services. After that, we've got what's called a disposition hearing, which is just setting up any other services that need to be set up, and reviews every 3 to 6 months to see if we can get those kids returned. So just once again, here's a little bit bigger lettering on that so you can see what happens. Protective custody hearing, pre-hearing conference, first appearance, and then our trial and plan for follow-up. Not to say that there aren't parents that get help right away, whether it's through our courts, whether it's on their own, whether it's that they have a criminal court filing as well. But some of these people, they really work hard and they have the resources. But if you don't have the resources, it makes it very difficult to get the help that you need. Everybody has an attorney appointed because in all the 30-something years that I've practiced law, you will see that it's so much time and energy. It's really, really expensive to hire an attorney. I would say maybe 2-3% of the cases do I ever see attorneys that have been hired. So court appointment is normally what you're going to see. There are other players involved in the court system that are very helpful. One of them is CASA. I don't know if you've ever heard of CASA, but CASA is a voluntary service that is throughout the state. They're able to go out and spend more time with the kids. They write up their own reports. We've got the Foster Care Review Board. They do a lot of our statistics so that we're not losing the kids in the system. And they meet and send out reports on that. A lot of these people have probation officers, and not just in a punishing way, but probation a lot of times can provide services for people with substance use issues, such as evaluations. Because in a lot of our counties and districts, we have grants so that they can get a free evaluation. They can provide vouchers for treatment, which is very, very expensive. And the other really important component here is the ICWA, which is Indian Child Welfare Act, which provides for anyone that meets a certain level of blood as far as Native American. They not only deserve and get representation, they have a whole different series of protections over them through the federal courts. So they're involved throughout the process. They have their own treatment facilities. None of that costs money for them. It's just sometimes getting them to go there can be difficult. So what I was talking about with timing and the difference between just treating our patients on a day-to-day basis is that under 43292.02 is that if you've got children that have been in foster care for 15 out of 22 months, it is required that a termination of parental rights is filed. And this puts everyone at risk of parents losing not just custody, but their parental rights. And there's no going back on that. So that can be a lot worse than spending a great deal of time in jail. So there's this rushed feeling on that. And as most of us will know, if we've ever had any experience in working with someone with substance use issues, there's sometimes a waxing and waning with treatment, and maybe they make progress, but then they relapse and have to start from scratch. It makes it difficult, and they feel anxious and they feel like they failed, and some of them just give up. But there are some exceptions to this, and it's important to note these because if they are sincerely trying and they're working at it, they're trying to stay clean, they open up about what's going on, then we have some exceptions that might be very helpful for them. One of them is that they can show that they're making great progress. They have to have somebody that advocates for that. Yes, they did test positive again, but now they're back on track. And you'll see that with the medical community is extremely helpful with that, with their therapists, with their caseworkers. If they're interested and they're trying to make that effort, then a lot of times we can use that exception to say, let's give it a little bit more time. It does have to come before a hearing in front of the judge. Another thing is the Indian Child Welfare Act allows for parents with substance use issues to have more time because they are under a higher standard than what the other part of the community is. So if you can say that they are making efforts or the tribe is involved, then we may get more time on that. Also, kids that are placed with relatives or in kinship placement, which is someone that the child already knows, are sometimes allowed to have longer than 15 out of 22 months. The other one is if you've got kids that are 16, 17, 18, you may not want to terminate parental rights because they're almost at the age of independence. And those kids a lot of times will go into an area of independent living rather than trying to get into foster care. So in some of my smaller communities, what I'm seeing is that definitely substance abuse disorder plays a major role in parents losing their custody of their kids. I'd say 80% of the cases. A while ago, it used to be more like punishment, physical punishment, or just, abandoning and anything like that. But right now, I would say the majority of the cases have to do with substance use, which also, of course, leads to other issues such as not being there for them or not being able to provide for them because they're using the money for other resources, just not able to take care of the kids as much. Even just in the news, it shows that at this point, half of the kids were removed because of parental substance abuse, along with other things. And that's also being reported by the foster care system. The kids go to, when they come in, and if there's abuse involved, they go to Project Harmony and they go through a whole series of testing, even for their medical help, and they see a dentist and they do an eye appointment. But Project Harmony on these forensic interviews is able to identify that along with the substance use that the parents are dealing with, there's a lot of other abuses that go along with it. Like I said, with just not being there, or sexual abuse and other people being involved in these kids' lives that are not healthy for them. And there is just a lot of stress. Child Protective Services, they're noting too that they're trying to put all sorts of resources in the home for parents with addiction issues, and trying to get family support workers, trying to get therapists set up, trying to get them into a program with the clinic that does substance use. They know what they know, so they try to set that up. But these facilities are out there, but if you don't have the money, you don't have the resources. Also, parents that have kids in the home and are low income usually have Medicaid. But if you lose custody of your kids, you also lose your Medicaid or your insurance benefits as if your kids are no longer with you. So that provides another stressor. Okay, so I just have a few of these graphs in here, and basically what we're looking at is some of these removals, and as you can see, it's kids of all ages. Babies are really problematic because you take them out of the home, parents are incarcerated, there's no bonding. A lot of times you're seeing bonding occur between the foster parent or the other family kinship, other family members, and trying to reunite them is difficult. You notice it kind of trends down a little bit in 2021. We had a lot of problems during COVID with kids not being found out about. And there was a lot of problems with substance use, of course, as there is all the time, but caseworkers weren't getting out to the homes because we were all worried about getting infections. And so there's just like a little bit of a lack there. These are just trends on removals. And you always notice that when it's time of year for school, that you got more eyes on for kids. If they go to medical appointments, there's eyes on for kids at that point. And a lot of these kids, when we do these first meetings, oh no, they haven't been in for their shots. So no, nobody has seen them other than maybe at an urgent care or something like that. So they're not getting medical attention, and same for the parents. Okay, so I did the best that I could with this. This is what I know, and it's somewhat limited, and you all might know a lot more about this than I do. But there are substance use disorder treatment facilities throughout the state. Some of them provide inpatient care. Some of them provide inpatient, intensive outpatient, and outpatient. These are some of the ones that I know have an inpatient. And I'm familiar with a number of these. Some of them I use more than others when I'm trying to get somebody help because they will take Medicaid, they will take Medicare, they will take a voucher. Some of them don't. So just depending, you've got like North Point, I think their program's 29 days, but correct me if I'm wrong, that their intensive outpatient program appears to be pretty good. I think that they provide like not just sitting there watching films. I think they're interactive. Valley Hope, I've had good experience with them. They're way out in O'Neill. So just say you make a decision to get help there. You go way out to O'Neill. You don't bring your car. It's a little bit hard to get back. So maybe you're going to stay for that time. And, a lot of these other programs have a good recovery resources. But it's all based on the person, and sometimes one-time stay in these places doesn't take care of it all. I do have some that are my favorites and some that I feel like, make it a little bit more difficult. Also, the Intertribal Treatment Center is there for Native Americans, and that's important. Okay, so here's a few of places that I'm familiar with, because you can bring your kids. Heartland Family Works, great, really hard program, but if you call every week, there's a really good chance that someone can get in there. You can't bring in your phone, you can't bring in any of that stuff, but you can bring your kids, not in the very beginning, but a little bit down the road. So that program seems to be working really, really well. And I feel like every time I talk to them, I'm saying, thank you, because I feel like the progress there is amazing. The Well seems to be a really good program. It's long-term, so you're in a place and then they set you up with a place to live after that. It's more women. And there's also Bart Methadone Clinic. I'm not really familiar with that. I just put it in there because I saw that on the list. Okay, like I said, best recommendations. Hang on, I got a cough. Sorry, guys. Family Works is my number one recommendations. It's long-term. They check in. It's nicotine free. It's family centered. Lydia House is another option for moms. Nice thing about it is they don't require an evaluation, but you got to call every day, and sometimes not as organized in the way that they do things. So you have to be really fired up to get into there. Santa Monica, valuation is required. Hard to set up evaluations sometimes because they do cost money. So we try to get those from resources. And if you guys know of any resources to get evaluations, please feel free to put that in the chat or chime in. Men, so Salvation Army, really, really good treatment because they also set up jobs and just a whole spiritual aspect to that. Nova, which is out kind of in the Ponca Hills area, feel like they've got a good program. There's Stevens Center, Center Point, Sienna Francis House, and Valley Hope for men. Okay, so cost. And I've already talked about this, but it's expensive. Okay. Medical detox is expensive. I've got a couple of people this week that I would like to send to detox, but the average cost is really high. But we don't have a ton of services in order to do that. So if you've got somebody that you feel like is really needing to go through that, I've got a Native American mom that continually is using a lot of, and her problem is more alcohol with some opioid. But every time that she's going to try to go into treatment, she has to go to medical detox. Long-term inpatient rehab in Nebraska costs pretty high. Outpatient addiction treatment centers, not that bad, but still. And then I've got some costs for methadone treatment. So here's some places that do allow for Medicaid, Medicare sliding scale facilities. Stevens Center, inpatient, outpatient, Center Hope, Campus for Hope in Omaha. Heartland Family Services has an outpatient facility. Nova Treatment Center, inpatient hard program, okay? And Santa Monica House, inpatient as well. And here's some more. That BART programs, the VA, of course, which I forgot to mention, CHI, psychiatric, outpatient. Let's not forget about One World Community Health Centers, who helps a lot of people. And Lasting Hope Recovery inpatient does take Medicaid, Medicare. I know it may not sound like a good thing, but a lot of times if you've got individuals that get picked up for criminal activities such as possession of controlled substances or attempt to deliver or something like that, they may choose on the criminal side to become involved in adult drug court or DUI court. And they have a specialized team that works with them. They've got therapists, they've got probation officers, they've got the judge, they've got just a bunch of team members, and then they all work together. It provides a lot of sources for them to possibly tap into, such as housing, such as looking for a job, such as getting treatment. And if you ever get a chance to go to a drug court forum and see, it's a positive interaction for the most part because your peers are there and the judge is there, and what they're looking at is making progress. And recidivism has been going way down. I don't have those statistics with me today. And that's what I have. So let's see if we can take it back to, how do I get back there? Our question that we have.
If you hit maybe the back, or there you go. Yeah.
Okay.
So go back to that case you talked about at the
All
beginning.
right.
Yeah.
Okay. So back to our mom. And this is going on a lot with some of these cases. There's so many issues going on with them all at one time. Wants to get help, wants to get treatment, isn't in a facility at this time. a lot of pain. I mean, some of this past domestic abuse has been really serious, and so she's struggling with that. Is finding some help with using the opioids, and also has meth addiction issues. So anybody have anything that they would like to chime in about on any other medical treatments that are available outpatient? Um, Anybody on consider some possible help for mom within the medical community, any type of resources that might be available? Or are there any noted health concerns that could be addressed at this time prior to going inpatient?
And I'm monitoring the chat. Feel free to drop some suggestions in the chat. So this is a mother with fentanyl, heroin, and methamphetamine use, correct, Mary?
Correct.
And the children have been pulled out of the house. So what, I guess, yeah. So the first question is what are some medical treatment options? And Echo Team, feel free to chime in. Ed, do you have any thoughts?
I appreciate the presentation. I have a lot of questions about that. Um, can you tell me more, Mary, about the evaluation side of things? So, like, I think as we're thinking about this patient's treatment, like, I know one of the requirements a lot of times is like this evaluation. And in our company, like, that happens outside of what I do. So, who's doing that evaluation? What exactly does that evaluation mean? And who gets that information? Is it for the court or is it for the individual or both? And how does that like sort of help guide treatment for these individuals?
So the evaluation is normally done by somebody that is authorized to do a substance use evaluation. Um, I feel like it slows down sometimes when they do what's called an IDI, because that evaluation just says, well, this is what I see as all the needs. Um, what I like to see, and in this particular woman's case, she had what was called a co-occurring evaluation, which stated she's got depression, she's got anxiety, she's got severe addiction issues to opioids and to methamphetamines. So that's basically what it read. The evaluation goes to whoever she signs releases for. So in this particular case, I was assigned as her attorney. I do a lot of guardian ad litem work, but in this case, I'm representing her. So I got that evaluation. Her caseworker gets the evaluation. The evaluation was paid for by probation because she was also picked up for criminal charges. As far as the child abuse, it wasn't just in the juvenile court system, it was also in the criminal court system. And once that evaluation came out, then it could be shared with the different facilities that she was looking at. So she has been accepted to Family Works, but there's a waiting list. So, it's going to be probably a month to a month and a half. The other day, we talked about possibly going through some type of detox program in the meantime. you know, uh, the caseworker is trying to help her with that while she still has Medicaid, since the Medicaid has not been dropped yet. But she's kind of unaware of that and was talking about maybe going to Douglas County and having her detox there. Um, so in this particular case, you've got an individual that's open enough to say, look, I want to reunite with my kids as quickly as possible, but I also have all these issues that I'm dealing with. Does that answer that, Ed? The
Yeah, that's
question?
helpful. So like again, on the evaluation side of it, like they're sort of just saying like what we sort of already know. This patient has polysubstance use and they need treatment. Are they telling you like the patient must go to inpatient or they should do outpatient or they should do like are they giving like guidelines and then is like the court holding them responsible for that or like who's deciding where they go and like because like when I see patients in the we do like some screening side of things, and it's like, hey, the recommendation is inpatient, whatever, but it's like the reality is that's not happening, so we're treating them in an outpatient sort of basis, but we're not like bound by that. So how does that work in the court system?
So in the court system, all that the court can order is receive the evaluation and follow the recommendations of the evaluation. So if you get somebody early on and they go into an evaluation and they say, I haven't used in 3 weeks, then you're going to probably get back an evaluation that says, oh, try them in outpatient or intensive outpatient if they've got a super long history. If they go into this evaluation and they say, hey, I'm using on a daily basis, scared to come off the stuff. I mean, if you're getting a decent evaluation, what you're going to see is something that says inpatient. And then it's going to recommend that, and it's going to use words like severe and those kind of things, which helps us to get on that list and get them in a little bit quicker. Because insurance will cover that, right? As opposed to somebody that's got issues but is using like less frequently. So in her particular case, she's got a severe problem and she's almost afraid to come off of anything at this time to move forward. So she's kind of stuck with, I'm not able to get to be around my kids because she's not getting a lot of visits and she's not doing that well. So the evaluation comes in and then it goes directly to those treatment facilities.
And then what's the like, give us a ballpark like on this situation, what's the turnaround time? Like, okay, let's say they say recommend inpatient, like how long is that going to take? And you mentioned like there's this gap between like when they're going to lose their insurance, right? If there's like
Right.
a criminal charge, like, because it feels like it takes forever to get into any sort of inpatient, at least I'm working broadly speaking, but yeah, what's that look like time wise?
So, if unlike this particular person, it's like call in, call in, call in. So they're on the waiting list and they're ready to go. Just say she loses her Medicaid. In the meantime, what I do is I go back to court and I ask the judge to order that she's lost Medicaid. And if she has no other sources of income, then the department has to pay for her treatment.
Okay.
And the judge will order that so that she will be able to go through treatment. Otherwise, what are we doing? I mean, in the olden days, it used to be like they would require people to do all these external things that didn't have anything to do with substance use. But really, we're trying to focus on what is most important. And that's what's most important is to help them get clean, because once that's happened, everything else seems to do better.
Mm-hmm.
We had a comment in the chat saying this case brings home how little I know about resources for a very complex circumstance. It sounds like the arrest mobilizes some of these resources.
Yes.
I guess what are the steps to getting those resources?
Um, the steps to getting the resources are normally getting a caseworker on them. They have 3 levels of caseworkers through the department. And let me tell you, those people work hard for no money. But the intake workers get a lot of things started. They do a lot of the investigation. Then they do safety assessments and they look at what do we need to do right now. And so they're making phone calls, they're getting resources set up so that the family can have visitation, so that the family can have medical help. The kids get into some type of, they have to have physicals and have to have eye exams, dental, things like that. And that's the same for these parents. What do you need? That's why we have that meeting. And at that meeting, you've got mediation there, you've got probation there, you've got hopefully somebody that's therapeutic. You've got caseworkers, the parents, and anybody they want to bring. So I don't know if that answers your question, but
Yeah, thank you. Alex, did you have something to add?
Yes, thank you. Yeah, I love this talk. I also learned of some resources, even though I was aware of about half of them. And I love that one role got shouted out too. Our team works very hard to try to provide medical services, and we also do some medical work at the Stevens Center with my PA and my chief medical officer. Um, so I think that for this case, it's just kind of going around. There's a lot of medical options for different, like for the alcohol, obviously Suboxone will be a consideration. BART clinic, if someone's in Omaha, I can get there if they would prefer methadone for the opioids. But the question that came up for me as I'm listening to this is when we as medical clinicians are seeing these families, it seems like we have some influence and some sway if we can advocate and say, yes, this person's engaged in treatment and to try to help them put their lives together. If we're seeing them in the middle of like a 15-minute visit, where we've got lots of other people coming in, normal primary care day, who can we as medical clinicians say, like, who do I talk to? Like, is it the caseworker, or to say like, hey, if a medical thing would help, call me, or, to advocate for these folks. It seems like there's a lot of stuff that goes on with rehab and everything, and the legal system outside the clinician office that is not, that even if we know about it, we're not going to be able to contribute to that because we're too busy. But if we can like write a letter or like, advocate for someone, like, is it the caseworker that we would want to reach out to?
yes, the case was, so that's why we tell them, hey, you're going to these appointments, sign the releases. Okay. So even if you're super busy, if there's any way that we get sign releases on maybe what a progress note says or something of that nature, then what we can do is say, hey, can I get any of the notation from the last appointments? And if there's anything in there that says, hey, this person could really use this or that, we've got that. It's golden. And so they get started on it. And maybe I'm spoiled because I work with some of these caseworkers in some of these communities that are on top of things, even though I don't know how with the amount of cases, but they jump on that stuff. The thing that makes it hard for you guys is like when you're trying, you note something is there, but then you've got your 15-minute appointment and then you don't have time to do more than that. That's what that's what you have available. So if it's in the notes, that's super helpful, but getting a hold of a caseworker, if you can, would be the ultimate way to address it.
Thanks, Mary. I see a couple questions in the chat here. Here's the first one. Do court-appointed attorneys have special training in handling these difficult cases?
I would say some of them. The guardian ad litems have to do, they're the attorney for the kids, right? So they have to do outside training than any of the other attorneys in the state, in addition to what you learn as an attorney. The representation for the parents, there's a lot of really good attorneys out there that get specialized training because of the system, or that's what they do when they do their legal education. Some of them come in there and maybe are trying to do a good job, but they're fighting on everything in a case where a parent could probably do a lot better if they can buy into the immunity part of it and get those evaluations done and get moving a little bit early, just because there is a protection for their clients.
We have another good question here. Are there any outpatient or inpatient providers in Western Nebraska, or anything like monthly traveling clinics?
There
Um,
are, there
yeah.
are, and I can, if you give me a little bit, I can get back on some of that. isn't O'Neill, that's Western Nebraska, isn't it?
Yeah, and regional, and sorry guys, I don't have my,
Oh,
I'm
good.
driving,
I
so I
knew.
can't turn my video on, but Regional West does have an inpatient facility, and they, that's out in Scottsbluff, and they do, they will admit children, adolescents, and adults. I should know how many beds it is off the top of my head, but I don't. I am currently out in, Eastern Wyoming and Western Nebraska. I'm working on setting up kind of a satellite clinic in the Western Nebraska region. We haven't really solidified the details on that, but the goal is that way Western Nebraska on the Panhandle, there will hopefully be a clinic.
Hey, Stephanie, if when that happens, let me know, or if you know of any out there. Obviously, I'm kind of limited on
Yeah.
areas.
And another thing I wanted to add for your last question that I feel like a lot of Nebraska attorneys, and honestly in other states as well, it's not a federal law, but it is statewide, that if an individual calls 911 because they are concerned about an overdose, or they're concerned that their life is on the line because they took a substance and maybe they took too much, and the police do show up, they are protected from being charged with any crime. And it's a great law. It's probably one of my favorite things that was passed in Nebraska. And even a lot of attorneys do not know this. And so a lot of them are still charged. And so this is a simple law that you can easily get all those charges dropped if they were knowledgeable about what the protections they have. And so Mary's awesome. She truly is. She's wonderful at her job. And I wish other attorneys could be as knowledgeable as she is.
Did not know that 911 thing, so gonna use that in the future for sure.
Awesome.
And Alex put in a link to some resources from Nebraska DHHS, including a list of the behavioral health regions. That's always a good spot to start if you're looking for services in your area. They can usually make some good connections. See, we had another question come in. What does having immunity mean?
Immunity means that you cannot be charged with or prosecuted on anything that comes out of these confidential reports. So just say you have an evaluation, it shows that in the evaluation you maybe possessed or sold any type of substances, controlled substances, illegal substances, or you're using any of those substances, it is protected within the juvenile court system for the purposes of helping you get better, but cannot be shared with the criminal court system. You cannot be prosecuted on anything having to do with either the medical records, if you share those, or any type of evaluations.
We had a comment from Kelly saying, Pine Lake Behavioral Health and Medical does a lot of drug and alcohol evaluations and works hard at getting those individuals into the clinic as soon as possible. Thank you, Kelly.
Where is Pine Lake?
I know they have a location here in Lincoln. I'm not sure if they're anywhere. They may be other places. Someone else would know better than me.
It's at 9100 Andermatt, so it's by CHI, Nebraska, or yeah, CHI, Walmart, Menards. We're right there, off of Nebraska Parkway. I'm saying it correctly, instead of Highway 2. And so, yeah. And our team really does a great job of getting them in as soon as possible. I put my camera on, but I'm technically challenged right now.
Me too.
Thanks, Kelly.
And I also
Thanks.
want to add in that I'm licensed in all of the surrounding states, and so even if I'm physically not located in Nebraska at that moment, if it doesn't work out for that particular day for patients, I do see telehealth as well for substance use. Now our new DEA rules might change things up a bit, but I personally I see a lot of patients for Suboxone, buprenorphine, all substance use, and I create an individualized treatment plan since there's not a lot of residential or IOP or partial hospitalization programs. So I do like a weekly individualized program with patients. So if you guys have any patients out in the Western Nebraska or kind of that region, then certainly I can send you my contact information to be able to set up telehealth.
Awesome.
Hey, Mary, I have one more kind of question and comment. The question is what substances are you primarily seeing in Nebraska, and what can be helpful? My comment is as providers, a part of ECHO and engaging in these conversations, even what Alex was saying is what can I do to be helpful in the limited amount of time that I have to meet with an individual. Let's say that this patient comes to me for medical care, and I always just like to stress the idea of hey, when a patient comes in with polysubstance use, right? Multiple substances, alcohol, methamphetamine, opiates, whatever. And again, I may be biased just because this is the side of the work that I do, but we always say hey, if we can stabilize the opiate use disorder initially, we're actually giving these patients a really good opportunity to settle their brain down, get on a medication, get in a treatment program. And the other, I think the cool thing about what's going on here is hey, that's actually a pretty simple thing as a provider that we can help you walk through if you're not doing it already. But you could be a small piece of the puzzle, right? We initiate them on the medication, we help them get started, and then they're getting all of these other resources, these other follow-up opportunities. So I think sometimes when we hear the stories, it's a little bit overwhelming of how can there's so much going on here, how can we help solve the problem, right? But I think of being willing to, hey, if they do have an opiate use disorder, we can really help stabilize them, and that can be a piece of the puzzle that we play, getting them on the medication and moving forward. But the initial question was what substance are we seeing in Nebraska that are in these cases most often, or is it polysubstance use?
I mean, exactly what you said. You got a lot of people with opioid issues, and, if anybody could kind of ding in on the one issue. So you've got that. Of course, we've got really severe methamphetamine disorders and alcohol. To the point, we've talked about all these, but I feel like the opioid thing is the most dangerous. And when I talk to people struggling with this stuff, they know that, but they don't know where to go. So they go into the doctor, they're suffering, and they're coming out of there. A lot of them, we don't know this. Okay, so you've got these problems, you just need to go inpatient, right? But like you said, inpatient takes a while to get to. What do we do in the meantime? If we can just address the one issue, like you said, maybe that you can get that done within that short period of time and just make these suggestions, or something that Stephanie suggested, which is, hey, we can set you up with a telehealth appointment and maybe get started on a possible treatment plan that gives you somewhat of a roadmap to get started and not feel like everything is so overwhelming for everyone.
Mm-hmm.
So, yeah. Does that answer?
Yeah, definitely. And I think there's a component of that too, of just I think part of what we're trying to bring light to is hey, what resources are available, right? What providers are willing to see patients with substance use disorder, even though we're all supposed to be able to manage this from a DEA standpoint, but I also just think hey, if somebody comes to me in my practice and it's I have a month and a half before they're going inpatient, and I can confirm that they have an opiate use disorder, and I can help bridge a gap and begin to expose them to some treatment. And again, it does depend on if it's only alcohol, there's things we can do, right? If it's polysubstance, there's things we can do. But also just highlighting hey, as a team of ECHO people and as a team of people who are attending these sort of meetings, our hope is that we can get that information out there and make people more comfortable and just playing the piece that sort of we can play as providers in supporting those individuals. Because a lot of times some sort of law enforcement engagement is the thing that gets people to the point of making a decision or moving towards some sort of, treatment options for them. So
absolutely. It's hugely impactful because that month and a half can make a huge difference. So,
and Ed, I wanted to kind of reiterate what you said before about the polysubstance. And where we talk about kind of choosing one a substance to approach, and this is the one recommendation that I give the main one that I give across the board regarding treating substance use is always stick with one. Not pretend that the others don't exist, but allow the patient to be okay with helping them be okay with continuing to use the other substances as they are, and only focusing on, for example, the opioid use. Never doing multiple substances and weaning them off at the same time, because the odds of them being successful are really, really low.
Yeah, I totally agree with that. If a patient came to me and they didn't have an opiate use disorder in this situation, I would almost feel like more like, oh man, this is going to be super hard, because like at least I know with opiates, like I can give you something that's going to help you. And a lot of times when I help you with one of those things, it's going to help with the other things. But like it does get even more complicated when there's not a good medication side of things that we can push people towards.
Yeah, and this is this is where we have to really, get creative on the. This is where I get creative on the individualized treatment plan, where I'll have people. I require weekly follow-ups on an outpatient setting, and I don't check urine drug screens or anything, but I'm just having that face-to-face time, and it means quite a bit to these patients, because they haven't had that before. And then making sure we get patients onto Vivitrol, example, if they're not on opioids, of course, but if they're just on alcohol, I mean, that's going to be the biggest help to them over oral naltrexone, is getting them on to Vivitrol, things like that.
Excellent. Hey, great presentation, Mary. Looks like we're at the end of our hour here. There's a link in the chat to get your certificate. I'll also be emailing that out in around an hour or so later this morning. Like I said, we'll be back in April and May with some new training, so keep an eye out for those. And thanks everyone for joining us this morning.
Awesome job, Mary.
Thanks,
Great
Steph.
job. And Echo, great job, Mary. Yeah, Echo team, if you have time, we can jump over to that other link for a quick meeting, but no worries if people got to run too. Thanks.
Thanks.